Welcome to the Clinical Neurology with KD podcast season 2. After the overwhelming response to season 1, which focused on neurological localization for medical students, we are back with a brand new season dedicated to an exciting and often challenging topic of neuro-ophthalmology. If you haven't listened to season 1, I highly recommend doing so. It will help you understand the fundamentals of neurological localization, which forms the foundation for this season. The podcast aims to help medical students enjoy the process of learning neurology by teaching it from a clinical perspective. This season will benefit medical students, medicine, ophthalmology, neurology residents, and consultants. Each episode starts with a pre-test of multiple choice question based on the topic discussed. The answers will be provided at the end of the episode. Study materials, illustrations, and clinical resources for the podcast are available in the show description and on the neurologyteachingclub.com website and Instagram page. I'm your host, Dr. Krishnadas NC, and let's get started.
Welcome. Today we are discussing the abducens nerve. You probably know it as the sixth cranial nerve. Our plan is to trace its path, figure out what goes wrong, and maybe most interestingly, how problems here can show up in really unexpected ways. It's almost like a medical mystery sometimes. And we'll definitely touch on this idea of false localizing signs, where the symptom points one way, but the cause somewhere else entirely. The abducens nerve is a perfect example. Okay, let's get into it. So, maybe start us off simple. What is the main job of the abducens nerve? What does it actually do?
Right. Well, as its core, it's pretty focused. It supplies just one muscle, the lateral rectus muscle, on the same side of the face. And that muscle's job is to pull the eye outwards, away from the nose.
So, abduction, moving away from the midline.
Exactly. Abduction seems simple, but the journey that nerve takes to get to the muscle, that's what complexity really starts.
Okay, so where does this journey begin? As usual, in the brainstem?
Yes, it starts in the brainstem, specifically in the pons. There's a little control center there called the abducens nucleus. But here's where it immediately gets interesting. This nucleus doesn't just have the motor neurons that tell the lateral rectus to move. It also contains these special neurons called interneurons.
Interneurons? What do they do?
They actually connect via a pathway called the MLF, the medial longitudinal fasciculus, to the other eye's medial rectus muscle. That's the muscle that pulls the other eye inwards.
Ah, okay. So it's coordinating the pair.
Precisely. It ensures that when you look to say your right eye moves out and your left eye moves in, nice and smooth. It's conducting the whole horizontal gaze movement to that side.
Wow, so much for simple function, already coordinating across the midline.
So from the nucleus, the nerve fibers bundle together into what we call a fascicle. And this fascicle has to travel forward through a really crowded part of the pons. It passes near the facial nerve fasciculus and other major tracts controlling sensation and movement like the medial lemniscus and corticospinal tract. It's like navigating rush hour traffic.
A delicate route then.
Very. And it finally pops out of the brainstem right at the junction between the pons and the medulla.
Okay, so it's escaped the brainstem's rush hour. But I get the feeling its adventure is just beginning. You mentioned twists and turns?
Oh, absolutely. The journey outside the brainstem is long and pretty precarious in places. First, it enters the subarachnoid space. Here it actually has to cross over an artery, the internal auditory artery. And then it starts climbing up the clivus, which is basically the bony slope at the base of the skull.
Climbing up a slope? Okay.
And then it hits a really critical bottleneck, Dorillo's canal. This is a tiny channel formed by bone and a tough membrane called the dura, right near the tip of the petrous part of your temporal bone.
And why is that spot so important?
Because it's really narrow. This makes the nerve vulnerable here. If you have head trauma or if the pressure inside your skull increases for any reason, the nerve can get squeezed or stretched right at that point. It's a classical site for problems.
Makes sense. A tight spot is always a weak point. Where to next?
Next up is the cavernous sinus. This is a complex space on either side of your pituitary gland, kind of like a venous channel filled with important structures. And the abducens nerve does something unique here. It's the only cranial nerve that actually runs through the middle of the sinus right next to the internal carotid artery. The others are sort of embedded in the sinus wall.
So it's floating free in there, relatively speaking.
Kind of, yeah. It's medial to some other nerves like the ophthalmic part of trigeminal nerve and below the oculomotor nerve. It even picks up some temporary passengers here. Sympathetic nerve fibers heading for the pupil travels with it for a short distance.
Fascinating. And the final leg?
The final leg is into the orbit, the eye socket itself. It passes through an opening called the superior orbital fissure through another little fibrous ring called the annulus of Sin and finally reaches its target, the lateral rectus muscle, ready to tell it to pull the eye outwards.
What an incredible journey. All that complexity just to move the eye sideways? So, okay, let's switch gears. What happens when something goes wrong along this very long, very specific path? What does a person actually experience?
Well, the classic symptom of an abducens nerve palsy, meaning the nerve isn't working right, is double vision, specifically binocular horizontal diplopia.
Binocular meaning it only happens with both eyes open, and horizontal?
Exactly. If you cover one eye, the double vision goes away. And horizontal means that the two images appear side by side, not one above the other. This double vision is usually worse when looking towards the side of the affected eye and often worse when looking at distant objects.
Okay. Side by side double vision, worse looking out to that side makes sense. What else would you see?
You would see that the affected eyes just can't move outwards fully, limited abduction. And when the person is just looking straight ahead at rest, that eye might drift inwards towards the nose. We call that esotropia.
The eye turns in because the outward pull isn't working.
Precisely, the inward pulling muscle, the medial rectus, is basically unopposed. And this inward turn, this esotropia, gets much more obvious when the person tries to look towards the side where the nerve is weak.
That sounds pretty clear cut. But you mentioned earlier the brain can compensate sometimes. Can it hide this?
It absolutely can, especially if the weakness is mild. The brain has this amazing ability called fusional vergence. It works hard to keep the images from both eyes aligned. If the misalignment is small, the brain can often overcome it, especially for near vision.
So someone might not even realize they have double vision?
Not initially, or only in certain situations like when they are tired or looking far into the distance to the affected side. Sometimes the only clue is something called esophoria, a tendency for the eye to drift inwards that's usually kept in check by fusion. This can be uncovered with specific tests like cover-uncover test.
Right. The brain trying to paper over the cracks. So this brings us to the detective work. You have got the symptoms, the double vision, the limited movement. How do you use the nerve's anatomy, that whole journey we just traced, to figure out where the problem actually is?
That's the crucial next step, localization. Knowing the anatomy is key. Let's think about the different locations along the path. What if the problem is right back at the start in the nucleus or in the pons?
Okay, the control center itself?
If the nucleus is damaged, maybe by a stroke or a lesion, you don't just get weakness in the one lateral rectus muscle. Remember those interneurons connecting to the other eye?
Ah, right. The ones that coordinate the horizontal gaze?
Exactly. So a lesion in the nucleus causes a horizontal gaze palsy to that same side. The person can't look sideways properly with either eye towards the side of the lesion. It's a much bigger deficit than just one muscle.
That's a huge clue. Then not just one eye, but the coordinated movement is gone.
Precisely. There are also some specific syndromes linked to nuclear problems. Mobius syndrome, for example, is a rare congenital condition, often involving bilateral six-nerve palsies, so affecting both sides, along with facial weakness and other issues. It's a developmental problem in the brainstem.
Whoa, bilateral. Okay.
And then there's Johan's retraction syndrome. It's quite fascinating. Often the abducens nerve or nucleus didn't develop properly. The eye usually can't abduct, can't move outward. Well, but the weird part is when the person tries to look inwards, adduct, the eyes actually retracts, pulls back into the socket, and the eyelid might droop a bit. It happens because another nerve, usually the oculomotor nerve, mistakenly sends branches to the lateral rectus muscle.
So the wiring is crossed?
Essentially, yes, you get contraction of the inward and outward pulling muscles when trying to look in. Interestingly, many people with Duane syndrome don't have double vision when looking straight ahead. They adapt, but the eye movements are very characteristic.
Incredible how the body adapts. What about slightly further along the path? Not the nucleus, but the vesicle. That bundle of fibers traveling through the pons?
Right, if the lesion hits the vesicle after it leaves the nucleus, but before it exits the brainstem, the picture changes again because it's traveling through that crowded area. You often get associated signs.
Like hitting those other pathways nearby?
Exactly. For example, Millard-Gobler syndrome. This is typically a lesion in the lower front part of the pons. It catches the abducens vesicle, causing an ipsilateral sixth nerve palsy, same side eye turning in. But it also catches the facial nerve fasciculus nearby, causing facial weakness on the same side. And it often hits the descending motor fibers, corticospinal tract, before they cross over, causing weakness on the opposite side of the body.
Okay, so same side eye and face weakness, opposite side body weakness. That really points to a specific spot in the pons.
It does, very specific localization. Now, sometimes a very small lesion can just hit the sixth nerve vesicle in isolation, giving you only the eye movement problem. But you always have to look for those neighboring signs, ataxia, sensory changes, other cranial nerves like fifth, seventh, and eighth, because they help pinpoint the lesion within the brainstem. Causes here could be infarct, bleed, tumors, inflammation, and MRI brain is usually essential to make a diagnosis.
Right. So, pons lesions often come with company. What happens once the nerve leaves the brainstem and is out in that subarachnoid space?
Out in the open, relatively speaking. Here it's vulnerable to compression, maybe from blood vessels or tumors in the prepontine system. But the really key thing here is its susceptibility to raised intracranial pressure.
This is the false localizing sign you mentioned earlier.
This is the classic example. The abducens nerve has a very long course within the skull, especially its vertical climb up the clivus. It's also tethered at both ends where it exits the brainstem and where it enters Dorillo's canal or the cavernous sinus. So if pressure inside the whole skull goes up, maybe from a tumor far away like in the frontal lobe or from hydrocephalus, or even from conditions like idiopathic intracranial hypertension, too much pressure, or intracranial hypotension, that is too little pressure, the brain can shift slightly, stretching this long tethered nerve.
So the nerve gets pulled taut like a guitar string.
Kind of, yeah. And that stretching impairs its function, causing a sixth nerve palsy. But the underlying problem isn't actually near the nerve's path in the posterior fossa. It would be anywhere causing the pressure change.
That's amazing. The eye problem is just a symptom of pressure, not necessarily a local issue.
Exactly. It's a super important concept. That's why if someone presents with just a sixth nerve palsy, especially if it's bilateral, you have to consider raised or lowered intracranial pressure and investigate accordingly, usually with imaging like a contrast-enhanced MRI and sometimes a lumbar puncture to check the CSF pressure.
Okay, moving along its path. What about problems near the clivus, that bony slope?
Lesions right on the clivus itself, things like chordomas, which are rare bony tumors, or metastasis, or an extension from an nasopharyngeal carcinoma, can definitely affect the nerve because the two sixth nerve run close together, can cause bilateral palsies. There's also Gottfriedson syndrome, that's a combined 6th and 12th cranial nerve palsy. The 12th nerve, the hypoglossal, controls the tongue and exits the skull nearby. Seeing both affected together is often a ominous sign pointing towards something serious like cancer invasion at the skull base.
A specific combination suggesting a specific, often serious location. What about that tight spot, Dorillo's canal and the petrous apex area?
Yes, the petrous apex. Problems here can be tricky to distinguish from subarachnoid issues just based on the sixth nerve palsy alone, but you look for associated symptoms. Is there facial pain? That might suggest the trigeminal nerve is also involved nearby. Is there ear discharge, hearing loss, or mastoiditis that points towards the petrous bone?
Like an infection spreading from the ear?
Exactly. That leads to Gradinego syndrome, the classic triad, sixth nerve palsy, facial pain, and otitis media or petrositis. It signifies inflammation or infection at the tip of the petrous bone, squeezing the nerve as it passes through or near Dorillo's canal. Of course, trauma, clots, tumors can also happen here. And again, raised intracranial pressure can stretch the nerve over the sharp edge of the petrous tip.
Lots of potential culprits in that small area. Okay, next up, the cavernous sinus and that other opening, the superior orbital fissure.
Right, once the nerve enters the cavernous sinus, it's suddenly in close company with several other important structures. So the big clue for problems here is the involvement of other ocular motor nerves, the third and the fourth.
So, if multiple eye muscles are weak, not just the lateral rectus,
Correct. If you see combinations of third, fourth, and sixth nerve palsies, often with pain behind the eye due to the trigeminal V1 involvement, and maybe even Horner's syndrome, you strongly suspect the cavernous sinus or the superior orbital fissure right next to it.
Horner syndrome. Remind us what that involves again.
Horner's involves a droopy eyelid, ptosis, a small pupil, miosis, and decreased sweating over one side of face. Sympathetic nerves controlling these runs through the cavernous sinus alongside the carotid artery and can get damaged along with the cranial nerves. Interestingly, if you have a sixth nerve palsy plus a Horner syndrome, it really localizes well to the cavernous sinus. Why? Because the sympathetic fibers join the abducens for a short stretch within the sinus, damaging them both there, and you get the specific combination. Also, the type of sweating loss can help differentiate it from Horner's caused by a lesion back at the pons.
So, the company the nerve keeps gives you the location makes sense. What kind of things cause trouble in the cavernous sinus?
A whole range infections, inflammations like Tolosa-Hunt syndrome, which we might discuss later. Tumors invading from nearby areas like nasopharyngeal carcinoma, aneurysms of the internal carotid artery, or thrombosis within the sinus itself.
Okay, and the final stretch into the orbit?
Finally, yes, the damage occurs within the orbit itself after the nerve has passed through the superior orbital fissure. Here you would expect the sixth nerve palsy, but you might also see other signs specific to the orbit like proptosis, maybe swelling or redness of the high surface, chemosis, or even signs of optic nerve compression if a mass is large enough. Trauma, orbital tumors, inflammation like orbital pseudotumor or thyroid eye disease can all affect the nerve here.
What a detailed map. It really shows how crucial that anatomical knowledge is for diagnosis. Now, you mentioned earlier that the most common cause, especially in older adults, is often simpler, less sinister.
Often, yes, the most frequent cause of an isolated sixth nerve palsy, meaning no other neurological signs, particularly in people over 50 years with vascular risk factors like diabetes, high blood pressure, or high cholesterol, is presumed to be ischemic.
Ischemic meaning lack of blood flow to the nerve?
Exactly. Microvascular ischemia affecting the small blood vessels that supply the nerve itself. It typically comes on over a few days to weeks, causes double vision and limited abduction, but importantly usually gets better on its own.
Oh, that's good news. How long does recovery usually take?
Generally, spontaneous recovery happens within 3 to 6 months, though it can sometimes recur later on. Of course, even if ischemia is suspected, especially in older patients, or if there is any pain like headache, you still need to rule out other things, particularly giant cell arteritis, which is an inflammatory condition affecting arteries that requires urgent steroid treatment.
Right. Always consider the dangerous possibilities too. Now, what about things that look like a sixth nerve palsy but actually aren't? The mimics?
The mimics. Yes, very important not to miss this. One is convergent spasm. This is usually a functional issue, not a structural nerve problem. The person seems unable to look outward and their eye turns inward. Esotropia, mimicking a palsy.
So, how do you tell the difference?
The key giveaway is that when they try to look sideways and the eyes turn in, their pupils also constrict. They get smaller and they might have other signs of functional overlay. It's like their near vision convergence system is kicking in inappropriately.
Well, the pupil constriction is the clue. Okay, what else?
Another is divergence insufficiency. These patients have trouble aligning their eyes for distance vision, leading to an inward drift, esotropia, and horizontal double vision, specifically when looking far away. Near vision is fine.
But can they physically move the eye outwards?
Yes, that's the key. If you test their eye movements one eye at a time, abductions, they have full abduction. The problem isn't the nerve or muscle strength. It's the brain's ability to coordinate the eye for divergence, for looking far away.
So, full movement, but poor coordination for distance. Got it. Any others?
Well, you can get esotropia from other causes. For example, thalamic esotropia, an acute inward turning of the eyes, sometimes seen after a stroke or bleed in the thalamus, thought to be due to the disruption of pathway controlling convergence. If the medial rectus muscle, the one that pulls the eye in, gets trapped, say an orbital fracture, it can physically prevent the eye from moving outward.
A mechanical problem, not a nerve problem.
Exactly. And then there are more general conditions like myasthenia gravis, which causes fluctuating muscle weakness that can affect any eye muscles, or thyroid eye disease, which can cause inflammation and stiffness of the eye muscles. So you always need to consider those broad possibilities.
It really underscores the need for careful examination. Okay, thinking bigger picture now. Sometimes it's not just the sixth nerve, but multiple eye movement nerves are affected together. What kind of conditions cause that?
Right. Seeing multiple ocular motor nerve palsies, third, fourth, and sixth, definitely points towards processes affecting the areas where these nerves run close together, like the cavernous sinus or superior orbital fissure, or towards more systemic conditions. One example is Miller-Fisher syndrome. It's considered a variant of Guillain-Barré syndrome. The classic triad is areflexia, ataxia, and ophthalmoplegia.
All three eye movement nerves affected.
Often, yes, patients can have dramatic external ophthalmoplegia, sometimes complete paralysis of eye movements. Interestingly, these nerves seem particularly susceptible because they have a high concentration of a specific molecule, the GQ1B ganglioside, which is what the antibody of Miller-Fisher often target. The good news is it usually responds well to treatment like IVIG or plasma exchange.
Okay, an autoimmune attack targeting those nerves. What else?
Wernicke's encephalopathy. It's caused by thiamine deficiency. Critical to recognize, the triad is confusion, ataxia, and ophthalmoplegia. The eye signs can range from nystagmus to palsies of the sixth nerve bilaterally, or even complete gaze palsies.
And this is often linked to alcoholism.
Commonly, yes, but also seen in severe malnutrition after bariatric surgery, severe vomiting in pregnancy, or certain cancers. The key is urgent intravenous thiamine replacement. Delay can lead to irreversible memory damage known as Korsakoff syndrome.
A treatable emergency then?
Absolutely. Then there's ophthalmoplegic migraine. This usually starts in childhood. It's characterized by episodes of headache associated with palsy of one or more eye movement nerves, most often the third nerve, but sometimes the sixth or others. It used to be considered a migraine variant, but now it's thought to be more of a recurrent cranial neuropathy. Diagnosis is one of exclusion, and steroids might help during attacks.
Migraine causing nerve palsies? Interesting.
And Tolosone syndrome. This is an idiopathic granulomatous inflammation, basically inflammation for no known reason affecting the cavernous sinus or orbital apex. The hallmark is severe boring retroorbital pain followed by palsies of the third, fourth, sixth in any combination. MRI shows inflammation in the area and typically responds dramatically to steroids.
Painful inflammation squeezing the nerves?
Exactly. And one more important one, carotid cavernous fistula. This is an abnormal connection between the carotid artery or its branches and the cavernous sinus, can be caused by trauma or happens spontaneously.
So, high pressure arterial blood floods the low pressure venous sinus?
Precisely. This causes congestion. Patients might hear a pulsating sound in their ear, like that is pulsating tinnitus, gets a very red congested eye, may have proptosis and ophthalmoplegia because the increased pressure in the sinus compresses the cranial nerves running through it. Again, often third, fourth, and sixth. Diagnosis needs angiography and treatment is usually endovascular to block the fistula.
Wow, so many different ways these crucial nerves can be affected, from tiny blood vessel issues to major systemic conditions. So let's try to wrap this up. We have gone on this incredible journey following the abducens nerve from deep inside the brainstem through all those twists and turns, bottlenecks like Dorello's canal, busy intersections like the cavernous sinus, all the way to the eye muscle. And we have seen how problems anywhere along that path can cause that characteristic inability to move the eye outwards, the double vision, but also how the accompanying signs or lack thereof are the real clues to finding the culprit's location.
Exactly. The localization piece is just so critical, and it really highlights the importance of understanding the detailed anatomy. Especially when you consider this false localizing sign, it's a constant reminder that where the symptoms shows up isn't always where the root causes lie.
It really makes you think, doesn't it? How often might we, in any field, see a surface symptom and jump to the most obvious conclusion when the real issue is deeper or further away? connected in ways we didn't initially appreciate?
It's a great point. It pushes us to think about the systems, about connections, rather than just isolated parts. Understanding this one nerve's journey really is a window into the incredible complexity and interconnectedness of brain and the body.
Absolutely. It shows the delicate balance and how the body finds these sometimes surprising ways to signal that something somewhere needs attention. Maybe something for you, our listeners, to ponder. What other false localizing signs might be out there in medicine or even other areas of life, just waiting for a closer look?
Thank you for listening to the Clinical Neurology with KD podcast. We value your feedback and it motivates us to keep podcasting. Please subscribe, rate and review the podcast if you find it beneficial. You can follow the Neurology Teaching Club on Instagram, Facebook or X for exclusive visuals related to this podcast. To receive new episodes directly in your inbox, subscribe to our newsletter at neurologyteachingclub.com. Please note that the podcast and online content are meant for medical education only and should not be used to guide clinical decision making or treatment. You can find more episodes on Apple Podcasts, Spotify, Amazon Music or wherever you enjoy podcasts. This is KD signing off. Until next time, spread knowledge.